My name is Alex Ziss. I'm a member of Healthcare for All's Consumer Quality Advisory Council and Campaign for Better Care. I'm also a member of the steering committee of the Cape Care Coalition and of the Coalition for Social Justice. I want to thank the Massachusetts Nurses Association for giving me the opportunity to present my thoughts on the Patient Safety Bill. I spent my entire career in healthcare management, including hospital administration and medical practice management. While I was an administrator at Falmouth Hospital, I had the opportunity to work with excellent, dedicated nurses, and also to negotiate contracts with the Massachusetts Nurses Association. There have been many changes to the healthcare system, including regulations and financial systems. Many of these changes have made life more difficult for nurses at the bedside. I must state that when I first heard of efforts in California to implement this change, I was opposed. I thought the nurses on the inpatient units would be able to refuse admission for a patient in the emergency room, backing up the ER and having the patient in a less appropriate setting. We've not seen that happen. In California, staffing mandates for hospitals have resulted in more nurses on the inpatient units and opening more inpatient beds, and there have been no ER backups due to this change. That state found that there are many nurses who would not work in hospitals with the staffing ratios and burdens on the nurses, but who came back to hospitals when the change was made. I've learned that Massachusetts has the highest number of nurses per capita in the country, and that many would work in hospitals if such changes were made. Talk about some of the changes that have happened in healthcare. Medicare changed its payment system in the 1980s, paying on a per-discharge basis. The way hospitals responded was to cut days from the length of stay in order to maximize revenue. When I was at Falmouth Hospital, the average of length of stay was about 7 days. It was a little longer when I worked at St. Luke's Hospital, New York City, a large teaching hospital. The length of stay is now about 4 days. The shorthand descriptions of how hospitals discharge patients when that happens is quicker and sicker. Patients used to be admitted for elective surgery on the day before the procedure. That gave nurses the time to know the patients and families and to understand the circumstances that the patients would be returning to upon discharge. Now patients are admitted on the day of surgery, and the nurses see the patient for the first time post-operatively, when the patient is at his sickest and most vulnerable. This, combined with the shorter time in the hospital, forces nurses to spend more time with each patient and may not permit time to get to know the family. For this reason alone, we need more nursing time and more nurses. We've also made changes in the sciences involved in outpatient care. We have new medications appearing on a regular basis. If you have any doubt, watch the television commercials advocating the use of new drugs. And they always say, ask your doctor. In many cases, the full effect of new drugs on those patients may already be taking is not known, causing drug-to-drug interactions that harm a patient. In most industries, technology reduces costs and eliminates jobs. In healthcare, technology increases costs and puts a greater burden on those using it, often on nurses at the bedside. One of my administrative responsibilities at several hospitals was the social work department, which included discharge planning. This used to be a cooperative effort between nurses and social workers, both having the time to know patients and families. The guideline used to be that discharge planning starts with the admission. With the reductions in length of stay, there's less time for patients and families with both nurses and social workers. It should come as no surprise that readmission rates have risen for patients who are discharged too soon or to non-appropriate settings. As stated previously, patients for surgery are admitted on the same day as the procedure and are at their sickest when they first meet their nurses. Medical admissions are more often on an emergency patients, and patients are sick from the beginning of their stay. In both cases, patients need more nursing care and more time. Hospitals have responded by reducing staffing, forcing nurses to work extra shifts rather than hiring more nurses. We know from research that more hours for workers results in more errors. Recognizing this fact, we've changed the hours that interns and residents are permitted to work reducing the number of hours and shortening shifts. We should be doing the same for nurses, who are with the patients at all times, when physicians are not. Finally, one complaint from hospitals is that hiring more nurses will increase costs. For the year 2010, almost every hospital in Massachusetts ran a profit. I should say surplus, since hospitals in the state are, in theory, not for profit. Hospitals need to make money to pay salary, for increases in supply costs, and to keep up with necessary changes in technology. Many hospitals manage to run surpluses that are higher than one would expect. Massachusetts General Hospital made an operating surplus of $183 million last year. Brigham and Women's earned a surplus of $112 million. Beth Israel Deaconess earned $84 million. And Cape Cod Hospital had a surplus of $22 million. That amount, if used to hire nurses, would permit an additional 366 nurses to be hired, more than the bed complement of the entire hospital. I'm not advocating that all that money be used to hire more nurses, but there's enough to hire more nurses to make certain that patients get the time needed for their care. And there are provisions in the bill before the legislature for hospitals that do not have enough funds to hire additional nurses. Patients need nurses for their care around the clock. The nurses should be fresh enough to perform all tasks. Patients have a right to expect that from physicians. They must have the same right to expect that from their nurses. Thank you.
And now I would like to introduce our next presenter, straight from Cape Cod Hospital. Shannon Sherman is a registered nurse who works on a daily basis under the conditions just described by Mr. Zis and me. She is on the front lines of this fight to keep patients safe, and she knows firsthand that passing the safe staffing bill is the best way to guarantee patient safety and quality care. Please join me in welcoming Shannon Sherman to the podium. Hi, Shannon. Welcome.
Good afternoon. My name is Shannon Sherman, and I've been a registered nurse for more than 10 years. I currently work as a med-surg nurse at Cape Cod Hospital. I love my work, but frequently find it difficult to deliver the care my patients deserve. After listening to Ms. Kagan's remarks about the impact of poor staffing on our patients, I am even more outraged. I am resolved to do whatever I can to see that the Patient Safety Act becomes law. While the general public may find reports about the devastating impact on poor RN staffing on patient lives alarming, sadly for me and for all nurses in Massachusetts, they are the bitter reality of our everyday experience. Often, nurses are so rushed trying to juggle everything to keep their patients alive through the shift that nursing techniques get compromised. The fact that the RN understaffing is life-threatening for all patients. One prominent study on this issue, published in the Journal of American Medical Association, found that for every patient that exceeds the 4 assigned to a nurse on a floor like mine, the risk of death increases by 7% per patient. The study found that if a nurse has 8 patients instead of 4, the risk of death for all 8 patients was 31% higher. As you can see, I am about to become a mother, and I find it ironic that in Massachusetts we have seen fit to pass laws to protect our children in preschool and daycare settings by mandating safe caregiver to child limits. But if those same children become sick or ill or injured and need to be seen at the hospital, there is no law to protect the number of sick children that one nurse must care for. Does this make any sense? In the middle of this crisis, over the last year, we have seen the hospital industry engage in layoffs of nurses, as well as our support staff, with many hospitals implementing hiring freezes, thus worsening staffing. We are moving in the wrong direction. Here at Cape Cod Hospital, hundreds of nurses were on the same sidewalk just a few months ago protesting our administration's refusal to agree to limits on the use of mandatory overtime and for the needed improvements to our staffing levels. This was despite the fact that our employer has posted record profits of more than $22 million. Fortunately, we were able to reach an agreement on these issues, and through previous negotiations, we are one of only 2 hospitals in the state that have specific staffing levels mandated by our contract. However, ensuring that our administration meets our staffing standards is a daily struggle, and resolving disputes can take months, if not years, to resolve through labor management process. Nurses should not have to go to such lengths to ensure our patients get the care that they deserve. I am here to send the message that the most important thing we can do to protect our patients and our hospitals is to provide people like me with a safe and reasonable patient assignment, which is enforced by the Department of Public Health and based on best scientific research. This legislation will accomplish this goal. While you are in the hospital, we nurses are your advocate. We are your protector, and very often we are your lifeline. I have joined with this group of advocates and activists to do whatever I can here on the Cape to ensure that the Patient Safety Act passes and that every patient in every hospital is guaranteed a safe level of patient care.